Good morning, everyone. Welcome to Pediatric Guardians. Thank you for joining us. If you're online, welcome. Please join us in the Conference of Food Care. Today's speaker is Dr. Cara Tillotson. She completed her medical school at VIA College of Osteopathic Medicine in 2013 and her residency right here at Carilion in 2016. She stayed on as chief resident, working as a pediatric hospitalist, as well as seeing patients in the Pediatric Endocrinology clinic. She became a full-time hospitalist at the Carilion New River Valley Medical Center, held faculty positions at both Virginia Tech Carilion School of Medicine and the VIA College of Osteopathic Medicine. She relocated to New York City for fellowship in 2021 and is a graduate of the Columbia University Pediatric Endocrinology Fellowship. She has since returned to Carilion Clinic to join the Pediatric Endocrinology team and resume her position as an assistant professor at PTC SOM. Please join me in welcoming Dr. Cara Tillotson.
Hello, good morning, everybody. Are you taking pictures of me? Okay.
Maybe Instagram famous.
Thanks for coming this early in the morning. I'm going to be speaking about identifying type 1 diabetes before hyperglycemia. This is the target audience for this is really our general pediatricians and our residents and our other subspecialists because there's been a lot of changes to this landscape over the last 5 to 10 years. Okay, there we go. I have no financial disclosures. I do have some handouts back there that are educational handouts for both doctors and for patients. They are from a drug company that makes the only FDA-approved medication for the treatment for delay of stage 3 type 1 diabetes. So I've provided those to you all because they are nice handouts for families, but I'm not getting any kind of financial payment from them. So my objectives today, really I want to summarize where we're at in type 1 diabetes and what's changed in the staging system, which is fairly new. Summarize our current recommendations for who to screen, so what high-risk individuals we want to target for our screening, and why we want to screen, including benefits for early detection of type 1. Plan for ways that we can incorporate this screening into our practice here at Carilion, and then also review steps on what to do when you have a positive screen, including when to refer to us, your peds endocrinologist. And then also I want to give you a couple of resources at the end that you can use both for your own education and also for educating your patients who might be at risk. So type 1 diabetes overview, I know this is going to be the most general of general for you all, but this is just a reminder that type 1 diabetes is an autoimmune condition. It is characterized by destruction of the insulin-producing beta cells in the pancreas. It often has onset in childhood, but can present all through life, and actually most of the new diagnoses for type 1s are actually adults, simply because most of your life is spent in adulthood, so you have more years to potentially be diagnosed. It requires lifelong insulin and a rigorous self-management routine, and it's increasing in incidence worldwide. Before we go into all of those nitty-gritty details, I want to talk a little bit about some history and of diabetes in general. I'm going to try to keep it brief. I'm starting in ancient Egypt in 1550 BC. This picture here that you see is on the top is Hesira. He or she is one of the world's first known physicians, and described a condition in the ancient Egyptian text that resulted in excessive urination and wasting away. Later, people felt like this was likely diabetes. Around the same time, several other ancient civilizations, including ancient China and ancient India, also were speaking about this condition. Excuse me. Okay. In 250 BC, the actual term diabetes was coined by the Greeks. This means siphon, or to pass through, referring to the excessive urination that they had. This was the time where they had the first description of diabetes written by a physician, so it described the natural course of the disease. And a classic quote that comes out of that is that they stated diabetes is the melting down of the flesh and limbs into urine, and life with diabetes is short, disgusting, and painful. Remember, when all of these were happening, the only treatment for this was death. There was no treatment at all. We didn't know what was causing it. We just knew that you lost a lot of weight and then you died. In 1674, Thomas Willis added the term mellitus, meaning honey sweet, to refer to the urine taste in those with in those with diabetes mellitus compared to those with diabetes insipidus, where the urine tasted insipid or no taste. I do want to point out that in ancient Egypt and ancient India and ancient China, they noted that if you put the urine on the ground, ants came to it, and so they didn't need to taste it, but this doctor did taste it in order to cause diabetes mellitus. Okay. So the first cure, I like to put into perspective that when, of course, I was talking about how type 1 was universally fatal, but when we first were discovering how this disease happened and the treatment for it, we didn't know that insulin was a thing. We had a rough idea that the pancreas was involved, but didn't exactly know why or how. So a lot of people put a lot of effort into finding this cure, which was the discovery of insulin. So in 1906, the first human received a medication called acomatol, which actually was a pancreatic extract and awakened briefly from a coma. That acomatol was made by a German doctor. And as you can see by the timeline, it was right before several wars. So the research really stopped because of the war and also because this wasn't a purified extract. So about half of the people who got it went into shock. This specific patient that awoke from the coma was able to stay alive for about 2 weeks to a month longer than expected. So that was a pretty big deal. In 1921, Drs. Banting and Best successfully isolated insulin from one dog and gave it to another dog named Marjorie and reversed her diabetes. This is Marjorie. There are many dogs that were used during these experiments. Marjorie is the only one that got a name because she was the first creature cured of type 1. She lived for 70 days, where the average when they took out the pancreas was closer to a month. Oh my goodness. I'm gonna just take a beat. Anyone have any questions so far about all this fun history? Okay. This is Drs. Banting and Best, and I put them second because I felt like the dog was a bigger sacrifice, which is great. 1922, so just almost a year later, Leonard Thomas, who was 14 years old at the time, became the first patient treated with purified insulin extract, purified pancreatic extract called insulin. And this is him several years later. And just to give you more perspective, these are two different individuals before and after insulin. So on the left was this child named Teddy Ryder, who actually remained friends with Dr. Banting up until Dr. Banting's death in 1940. And this guy, Teddy, lived into his 70s, and at the time was the oldest person ever alive to have received artificial insulin. The kid on the right is JL. He weighed 15 pounds prior to insulin. So really, you can see why this was considered a cure back then. In 1923, the first commercially available insulin was produced, and the patent was sold for $1 to ensure that everybody has access to it at low cost. I'll leave it at that. Between 1974 and 2007, we started to discover the type 1 autoantibodies, and we were able to identify and test for them in labs. 2015 is when we got our staging system for type 1 that I'm going to go over today. And in 2022, we got the first FDA-approved medication to delay the stage 3 type 1 diabetes, which is tillotson. Now, the most important thing I think of recent history happened just about a month ago. Mattel announced the first type 1 diabetes Barbie. This is her. She has a little heart-shaped continuous glucose monitor there on the side that I zoomed in on. So this was made with Breakthrough T1D, which is formerly JDRF, as an effort to increase representation. Happy to say she's sold out almost immediately, so I've not been able to get my hands on one yet. But someday, hopefully, they'll make more and we'll get a bunch for every kid who wants one. All right, so type 1 diabetes, it is still the most common form of diabetes in children and adolescents. It is associated with a genetic risk, so certain HLA types and other specific gene mutations put you at a risk for type 1. There are approximately 3 million people here in the US that have type 1, and of those, 167,000 are children. The annual incidence is rising about 1.5% to 2% per year, starting in 2005. We don't quite know why. For the general population, the lifetime risk for type 1 is about 0.3, so 1 in 300. But this risk goes up if you have a first-degree family member with type 1, up to about 15 times higher risk in those who have a first-degree family member. And some of that depends on who your family member is. So if your mom has type 1, it's about a 1 to 4% risk. The highest risk is if your, for your parents, is if your dad has it, there's a 6 to 9% lifetime risk. Siblings are 5 to 6%, and then monozygotic twins, it really depends on the study you look at. It's anywhere from 33 to 50% in most studies. Some studies cite as high as 80% for twin studies. This is the classic system that you probably learned about in medical school that talks about the development of type 1 diabetes. This is actually called the Eisenbarth model. It's originated from a study in 1986. So we knew relatively early on that you're born with a genetic predisposition of some kind. You have this questionable precipitating event. We don't know what that is. There's been a lot of studies into that. That could be a whole talk on its own. But after that event, your body makes some kind of antibodies to your pancreas, but you still have normal insulin release for a long period of time as your body is destroying those beta cells. Once you get to about 90% of your pancreatic mass gone, that's when the overt signs of diabetes occur. So you have the polyuria, polydipsia, polyphagia, and weight loss. You then replace insulin and can go into a sort of honeymoon phase is what we call it, which is where the remaining beta cells are able to function better when you take away the hyperglycemic state. So now we have a formal staging system that's changed just a little bit, and we're going to go into that. There's now 4 stages of type 1 diabetes. Half of those are before onset of any symptoms, and half of them are kind of where we classically used to diagnose diabetes, which is stage 3, and then stage 4 is long-standing. We know that people with type 1 will seroconvert long before they show symptoms. Most will seroconvert years beforehand, sometimes as long as decades beforehand. If you have positive antibodies, we can predict your risk for progression to hyperglycemia in stage 3 with about 100% if you have 2 antibodies. So we are able to screen people. If you were positive, we are able to say, yeah, someday you're going to develop type 1. We are not quite able to say when that will happen in their lifetime, but we know if it will happen. There have been a lot of improvements in lab testing, and these antibody tests have gotten much better. So now we're able to test asymptomatic individuals and get fairly good data from that. The involved antibodies we're looking at, about 90% of those who are newly diagnosed, like with stage 3, will have at least 1 antibody positive. There are 5 total antibodies, and this is the list of them. So the ones that a lot of people remember that have been around since the 70s, 80s are the GAD65, the insulin antibody, and the islet cell. IA2 antibody is insulinoma-associated antibody is a more specific test compared to the islet cell antibody, but it's looking at the same antibody, basically. The zinc transporter 8 we just discovered in early 2000s, and that and the IA2 are both associated with higher insulin need or a more progressive course. So a shorter honeymoon course tends to occur more in the younger kids as well, who are known to have a higher rate of progression quicker compared to older people. So this is our staging system. Now you'll notice that this looks very similar to our Eisenbarth model that we're used to. You're born with a genetic risk, that's that risk assessment. You have something that causes immune activation, you have immune response. But now the new staging system divides up that time before you develop overt diabetes into 3 stages. So stage 1 is where you have 2 antibodies and a normal blood sugar. So this is where you pick people up on screening, so sibling screening or through research trials. Once you have 2 antibodies in your system at any point, you have a 5-year risk for progression to stage 3 type 1 of 44%, a 10-year risk of 70%, and your lifetime risk is almost 100%. And we say almost because there's still people in those trials that screen positive that are holdouts. They haven't quite developed type 1 yet, or stage 3 type 1, but almost 100% of those patients have developed it by this point. Stage 2 is where you have 2 autoantibodies, so just like stage 1, and you have abnormal blood sugar that doesn't meet the criteria for diabetes yet. This is a phrase called dysglycemia, and on the next slide I'll show you the exact kind of criteria that people use for that. It basically means you're not quite to the point that you're having symptoms for type 1, but your blood sugars aren't entirely normal. So you might have a little bit of elevated fasting blood sugar, You might lose that first response postprandial and have higher spikes than you would expect. Or your A1C might be in the prediabetes range, but you're not going to meet the official criteria for diabetes yet. Once you get to stage 2, your 5-year risk is about 75%, and your 10-year risk is 100%. So once you start progressing, once that process starts, it's difficult to reverse it backwards, and you tend to go on to stage 3. Stage 3 is the clinical diagnosis of type 1 diabetes. That's what we all think of. Yes?
Are you going to talk more about HLA genotyping and prediction of diabetes?
Yeah, just a little bit, but not in full detail, but a little bit later. Stage 3 is the clinical diagnosis of type 1 that we're all used to seeing, the polyuria, polydipsia, polyphagia. And here's this just written out into a table for you all for the different types of learners, right? Visual versus read-write. And what I wanted to point out specifically on this table is the dysglycemia. When these staging systems first came out, I think there was a lot of discussion among endocrinologists that were like, what counts as dysglycemia? Is it increased variability? Is it increased A1C? What is it? These are the things that have been recommended to use as to diagnose dysglycemia. So an elevated fasting blood sugar, if you do an OGTT, then you have a not quite abnormal but not normal 2-hour post-glucose tolerance elevation, A1C in the prediabetes range, or a 10% rise in your A1C. So you go from normal A1C to normal A1C, but it's going up. This stage is where we can intervene with some of the medications, and also where I would say we want you to refer to us. Stage 4, I didn't mention in the last slide. Stage 4 is longstanding type 1. Diagnosis of that is 5 to 10 years-ish after diagnosis with type 1. You get longstanding, which means you just don't make any insulin or very, very little, not detectable levels of insulin for the rest of your life. All right, so why do we care about staging? Like, what are the benefits of early diagnosis? I want to start with the why, because I think a lot of people are like, if I'm going to develop it, I don't really want to know. I'll just look out for the symptoms and we'll see what happens, right? But there are things we can do in that time, and that's why I think it is important that we think about screening early. So, personal opinion, I think one of the most important things are the psychological benefits. I'm going to go into the data on decreased hospitalizations and improved long-term outcomes. I put a question next to cost effectiveness because that's still being studied. But then on the, one of the things that a lot of people don't know about is that there are pharmacologic interventions we can offer to some patients to delay stage 3 type 1. And there are research opportunities available for patients to look into more of those studies. So I'll start with the psychological benefits. And these are this is from Camp 2 Suite, which just happened last week for diabetes camp. I tried to get a picture of all of the residents, and we didn't manage to because there were just so many residents this year. But we have some of our residents helping at med staff there. And then on the left side of the screen, that was from Skit Night, where we had people in the med staff dressed up as different diabetes technology and medications. It was a really cute skit. Dr. Reynolds was Ariel from The Little Mermaid, and all her neat stuff was all the diabetes supplies, so it was real cute. Okay. So I'm going to start with a couple parent quotes for you. And these are, long, but indulge me. This is from Kathy Sturm. She's one of our peds endocrine nurses now. She was not a peds endocrine nurse when her son was admitted to our hospital with type 1, new diagnosis, but he was diagnosed 11 years ago when he was 7 years old. And she said, "I will always remember all the emotions I felt in the hospital. He was so tiny and sick in the hospital bed. It was devastating to know that he would have a lifelong condition, and all I wanted to do was take it away from him. I was so overwhelmed learning how to take care of him because there was so much information. One lunch, the nurses came in and they disagreed about whether to count carbs for ketchup. And I thought, if they didn't know, how was I supposed to go home and figure this out? I was honestly so scared to take him home because I didn't know if I would be able to take care of my son." So that's one parent's experience, and I think a common one that we see. Most, depending on your system, most kids get admitted with new onset type 1, a handful don't, just because the amount of teaching is so significant. And that is a lot for them to go through. This is from my father. So I have type 1. I was diagnosed at 11, and my dad is listening here. So if anyone wants to say hi to him. So he said, I found out about my only daughter's diagnosis at 10:30 p.m. I was asleep, and my son woke me up to tell me. To say I jumped out of bed is not an exaggeration. I didn't know what diabetes was. I may have heard that Mary Tyler Moore had diabetes. I might have known that diabetics take shots, but I didn't know why. I did not know whether this was a deadly diagnosis. I'm not a medical person. I had to learn all about her condition and how to manage it very quickly. On top of learning what insulin is, how to check a blood sugar, what a ketone is, how to mix insulins, and how to count carbs, I had to put on a brave face for my 11-year-old daughter and pretend like I was not scared to give her her first injections. So the kids often do quite well, honestly, with their new diagnosis. The parents a lot of times don't, right? Like I was just like, okay, this is your life now. I didn't know my parents were going through this. So I say all this to say how patients hear about their diagnosis or how their parents hear about their diagnosis matters. So early screening gives time for things like diabetes education to begin at an outpatient standpoint and complete over months or years rather than days. All of the residents know those families come into the hospital and over about 36 hours have to learn what a pancreas is, what insulin is, all this stuff that like my dad talked about learning and Kathy talked about learning. And then they go home with their kid with this diagnosis and medicine that, oops, if you mess up the dosing, you could kill your kid. That's a lot of information to receive inpatient when your kid is already critically ill. Screening early allows them to get used to all of that and get this information in little bits and pieces before the kid is going to get critically ill. And there have been studies on the psychological benefits of this. Diagnosis of type 1 at any point is associated with increased parental distress and depression. It is never going to be something that people are happy to hear about. But parents of those who are diagnosed with stage 1 have lower psychological burden compared to those diagnosed in stage 3. When they do the studies on the depression scores for parents tend to improve from baseline to 12 months follow-up. So keep in mind, if we're screening early, we might be catching this years before diagnosis. So we have time for that depression score to improve. Yes?
So when should we be screening for this? Is it just in the family? Okay.
Don't worry, we'll go over that. And a new diagnosis before treatment is required, allows time for them to get counseling and mental health support as needed. All right, some of the other health benefits. There is decreased DKA at diagnosis. Multiple studies have shown a significant decrease in DKA episodes if you're diagnosed through early screening because you're being able to monitor for it. This is from a study that looked at a bunch of recent studies in the United States and elsewhere that just shows the rate of DKA on the bottom for those who did not screen versus the top for those who did screen. Excuse me. In Italy, there's actually mandatory screening by law that started in 2023 for the general population. They have to screen for type 1 diabetes and celiac disease. It is important that Italy has a high rate of both of these conditions, and that's why it has been put into law. But they only have certain regions that so far have actually implemented the screening. They just published data this week. There is a decrease in DKA and severe DKA by about 10 to 15%, but they also had the confounding factor that they had increased education on the signs of DKA with with the start of the mandatory screening. So it might not be totally representative of other populations. Okay, other health benefits include better long-term outcomes. Anytime that you're diagnosed, the sooner you can get your blood sugars into range and well controlled will result in better, less complications long-term. So if you screen early, you get an improved honeymoon phase because you get into control quickly. You might be able to remove that aspect of traditional diagnosis, which is poor control at the beginning, getting into control quickly. Like you might be able to just stay in control if you start treatment early enough. There's no direct studies on the long-term complications of type 1 in those who screened early, simply because those patients are just we're not there yet. It hasn't been that long. But we're going back to our classic study, the DCCT, which is the Diabetes Control and Complications Trial. The intense treatment group in this, and this was in the 90s, where intense treatment meant just multiple daily injections. So it's not an insulin pump. This was just long-acting and short-acting insulin versus just getting 2 shots a day. That group had persistent reduction in complications, even when later control deteriorated and matched those in the non-intense group. So there is a benefit to that early control. And the reductions are a lot, like 50 to 76% reduction in microvascular complications, and a 42% reduction in cardiovascular events. On top of that, those preventing DKA can also be linked to less long-term complications. So those who are in DKA at diagnosis, regardless of their later control, have higher complications than those who are not in DKA at diagnosis. There's also neurodevelopmental concerns with a child. So those in DKA are associated with lower cognitive and intellectual function and verbal IQ scores, as well as memory deficits later in life. And cost effectiveness, just very briefly, there's a clear cost benefit to preventing hospitalizations in DKA for those who do end up progressing. An average cost in the US for DKA admission is $30,000. But as far as for general population screening, that cost effectiveness is still being studied. There are limited large-scale population studies overall that show a lower cost with earlier diagnosis. And two, I want to highlight that did some general population screening is the ASK trial, which is in the US. This is autoimmunity screening for kids. This is out of Colorado, and they're screening for type 1 and celiac in the general population. About 0.5% have screened positive for type 1, which equates to approximately the general incidence of type 1 in it, so that it's a good representation of what we'll probably see larger scale. They did a modeling of the cost effectiveness in the United States and basically said it depends on the lab costs. So in this study, they had a partner lab that had discounted lab costs for these antibodies, so it probably doesn't equate to what it would be IRL for all of us. But they modeled out that a 40% reduction in DKA would result in cost effectiveness and savings. And this estimated that with early screening, you might be able to decrease that incidence of DKA by about 60%. In Germany, I just put this in here. There are studies in lots of different countries too that had kind of similar things, but in Germany they did large-scale screening greater than 90,000, and they said, yep, there's definitely cost savings. So obviously it depends on your health system. In general, in Europe, it has been shown to be very cost-effective to do this. So I anticipate they'll get universal screening before we do. Okay, the pharmacologic benefit of screening. There are more treatment options as well. So Tillotson, which is marketed under the brand name Tzield, is approved in 2022. It is the only medication currently on the market that can prevent or delay, the progression from stage 2 to stage 3 diabetes. It is approved for patients 8 years and above who have stage 2. That's that 2 positive antibodies and dysglycemia, so high risk for progression to stage 3 within the next 5 to 10 years. It is an IV infusion that is given once daily over 14 days, and how that is given really depends on your institution. Currently, it is only one course, it's not redosed. To be determined in the future if research shows that we need to redose it, but it has a median delay of 2 years from the development of stage 2 to stage 3 compared to placebo. The side effects of it are significant or can be significant. So cytokine release syndrome, lymphopenia, and immunosuppression, which is kind of what it's trying to do. It's trying to suppress the T cells in order to prevent them from attacking the pancreatic beta cells. So this is a medication that should be done by a pediatric endocrinologist. I would not expect a general practitioner to do this, but knowing that it's available helps you counsel families about screening. A lot of people feel, I don't want to screen because there's nothing I can do except catch it early if it happens. And yes, we know we can do all of the education, but a lot of families don't interpret that as doing something necessarily. This is a medication, so you can use this sometimes as a way to help them make their decision. This is my humble opinions, only mine. I don't know if my other endocrinologists would agree with me. I think all families who qualify for Tillotson should be counseled on it and offered it. I really think shared decision-making is very important for these patients. It is not an easy course. 14 days of IV therapy is going to be disruptive to their life. It is potentially going to be something scary to them, to a kid who's never gotten an IV before maybe. The side effects can be significant, so it's not like you can just take a pill and be great. So I understand if families don't want to do this, but I don't think we should assume that it's too hard of a course and we shouldn't offer it, because people surprise you in what they want and what they don't. 2 years of good glycemic control without the need for insulin could be very critical for a patient. This can mean the difference between getting type 1 before puberty versus after puberty. And that is a very traditional time where people become poorly controlled with type 1 and also have a lot of things like insulin resistance and difficulty to manage their type 1. It could also mean getting from age 8 years to 10 years old without type 1. And developmentally, there's a big change and difference there. So shared decision-making, definitely critical. I would never force a family to get this. There we go. Who to screen? Getting to y'all's questions. Who to screen and when to screen? So this is a changing landscape. Currently, the American Diabetes Association recommends screening any patients who are at increased risk, and this includes those who have family members with type 1, specifically first-degree family members, who have any other autoimmune condition. Celiac disease is a big one, inflammatory bowel disease, hypothyroidism, arthritis, lupus, etc. Any of those who have a personal history of autoimmunity should be screened. And anyone in the A1C and the pre-diabetes range, they actually recommend screening because you might be able to catch somebody who you thought was type 2 as also having antibodies, so maybe having a mixed picture of type 1. But we also know only 10 to 15% of newly diagnosed patients have a positive family history, and that's where the question of universal screening comes in. And these are some of the trials currently going on to determine the best way to do that. Now, this is where genetic risk score comes in. There are several genetic risk scores being used in research. So we know there's certain HLA types that are associated with type 1. There's also other high risks and nucleotide polymorphisms. Some of these scores, the one that's used the most, will incorporate all of this, including antibody status, to give a genetic risk score plus antibody, here's your risk of progression. So more fine-tuned than the 50%, 77%. To give you an idea, the GRS2, which is one of the scores currently being studied in the United States, uses 67 different SNPs to look at high risk versus low risk people. This may allow for more focused screening for those at high risk. So I will bring up Australia because I think that this is probably where most people or most countries will end up heading when we talk about universal screening. Australia has a pilot program currently. I want you to focus on the left. So on the right, this is a typical screening schedule that we'll talk about in a second. On the left, they've actually added a genetic risk stratification score into their newborn screen. So they can look at those HLA types when somebody's born, and if they're high risk, then they get their islet antibody screening starting at age 1 and repeated 2 to 3 times in childhood. And then if they get type 1 diagnosed, then they will be referred for clinical care. So this is a pilot study that still doesn't have data to show whether this makes it more cost effective. But given how diverse the United States is, and how large it is, this might be more where we're headed eventually, is maybe testing only those at high risk. Because if you look at this, the low population chance, that's going to be 90% of the population are not going to have these high risk HLA types. So you're going to capture most of your people just by screening those who are at high risk. All right, when to screen. We begin screening at least greater than 1 year of age. Type 1 antibodies are very rare, less than 1. We all know that that's not 100% the case. The youngest I've seen is a 6-month-old diagnosed with type 1. The majority of people, though, have to be around at least a year before their immune system can build antibodies, and that the development of type 1 antibodies start as early as 1 year old. You can screen those who are at high risk, like we talked about. And there's no formal screening age defined yet, but some authors recommend screening at 1 to 2 years or 4 to 6 years, kind of corresponding with peak incidence of early diagnosis, and then 11 to 13 years for that second peak, just pre-adolescence, knowing that a lot of people are diagnosed in that 11 to 15 age. If they're negative, you rescreen every 1 to 3 years until they're 18 years old. Then you could do every 3 to 5 years, but we also do know that if you make it to 18 years without antibodies, you're less likely to develop them later. So you might be able to get away with stopping screening at 18. And I'll talk about what to do when you're positive in just a second. How to screen, you can obtain any 4 or 5 of the antibodies, as many as available in your lab. These are the 5 antibodies, so IA2 or ICA are fine, but plus GAD, insulin, and zinc transporter 8. There are antibody panel orders. So here's the Quest code for type 1 autoantibody and the LabCorp code. There might be others at other labs as well. I just included those two because they're the most prevalent labs in our area. And then, excuse me. Ordering at Carilion. So Lori Wise is in the back here, and she's our nurse practitioner. We're working on eventually getting an order set so that it's going to be nice and easy for our general pediatricians. Because remember, these patients that are being screened are not our patients yet, so we're going to miss them. So these are things that are going to be screened in other clinics. Yes?
What about insurance coverage for this kind of testing?
Yes, so generally insurance is covering if you have a family history of type 1, if you're high risk. If insurance doesn't cover, the average cost is about $200 is the last thing I saw. So a family would have to decide whether or not to pay that, but generally insurance has been covering. Medicaid covers, for sure. I don't have patients with Medicare yet. I don't know if anyone here does, but I'm not sure if they cover, but reports from other places say that they have them. So until we get an order set up here, I've at least tried to make it a little bit easier for you all. This is actually my preference set. You can steal this from me. But you can see I have a diabetes screening / antibodies that's on the left side there. And there's the 5 different antibodies, as well as the Quest or LabCorp antibody profile, depending on what you want to do. And in case you don't know how to do this, if you go into your preference list, you can follow people. So, oops, let me go back. So you can see I'm following Erica and Reynolds and Lori Wise up here. So you can add me, my face will pop up, and I actually move this all the way to the top of my preference list. That way you all don't have to scroll and see all the stuff that you are not interested in. And you could just click which ones you want. And this is an example of clicking into the LabCorp one. I have it written down here, the LabCorp order form, or test order requisition, and the autoimmune profile. So I tried to make it as easy as I can for you all until we do get an order set. So then the question is, what do you do with the results? So if they're negative, like we talked about, you can rescreen. How often you rescreen really is going to depend. You could always talk to us because that's an ever-moving target right now. Most likely, let's say you have 2 positive antibodies, right? The easiest thing for 2 positive antibodies, you just call us, you refer to us, and we'll take it from there. We're going to be doing this bottom part of this slide. We're going to be staging. We're going to be doing the monitoring. We're going to be checking, monitoring at a certain frequency. The question's going to come when there's 1 antibody positive. Right now, a lot of these kids do, I think, get referred to us. Obviously, if we start screening more and more people, that might not be a very plausible thing, or the families might just not be able to come to multiple subspecialists for something that may or may not be clinically significant. So there are options. We do recommend the younger you are with 1 antibody, the more closely you should monitor them. So you could rescreen antibodies in 6 months for 3 years, every 6 months, and then every 12 months after that. Then you can stop. If they're greater than 3 years, you could do once a year for 3 years, and then if no progression, stop. And the reason for this is because if you have 1 antibody, you want to try to screen them again to see if you catch a second antibody popping up. These antibodies don't just all decide to activate at the same time. Once you have 1 antibody, if you rescreen and you're positive for only 1 antibody, but it's a different one, you still meet criteria as having 2 positive antibodies at some point. You still meet criteria for stage 1 type 1. So that's what you're trying to catch. And the younger you are, the more likely you are to develop more antibodies. Okay, my next slide kind of messed up a little, so let me get it here. There we go. All right, so this is the stages again, and I just put in on top of it what we do at each stage as a reminder. So stage 1 is when you can refer to us. We're going to start diabetes education and glucose monitoring, and we can always talk more about what that means, but it's not something I would expect you all to do in your general pediatric clinic. Stage 2 is where we can give diabetes education, closer glucose monitoring, and then we can offer immunotherapy. Stage 3 is, you all are familiar with that, right? We continue diabetes education. That's also where there's some opportunities for research studies as well. Some resources for you all. Trialnet.org. This is where the Pathway to Prevention trials are. So they will screen anybody for free who has a family member with type 1, or if people screen positive in your clinic, you can refer them to them for ongoing monitoring and potential research trials. So they are the ones that are doing all of the drug research trials into prolonging honeymoon phases, into prevention trials like with tillotson, et cetera. So TrialNet's a great option if literally anybody has a family member with it. They will send a kit to their house, which is a like finger stick kit. I hear it's kind of difficult to do the finger stick kit, but they can do that. They can try it. If that doesn't work, they go to a local lab to get their labs done. Screenfortype1.com, the handouts are here. This is from Sanofi, from the drug company, but it has some good information. It says like screen it like you mean it, like good information on why we screen for patients. AskHealth.org is the autoimmunity screening for kids. This is the one that's out of Colorado. They will screen anybody. You don't have to have a family member with type 1. It's all part of general population screening research. They can screen at their local LabCorp, and then if they screen positive, they can choose to then see somebody locally for ongoing care, or they can be part of their research trial in Colorado if that's feasible. So what's our future? We still don't know how to implement screening exactly. How many patients do we see with hypothyroidism? I've only screened a handful for type 1, even though this is in my world. So it's, we're slow to pick up on this. I would say that if you find a family history of type 1 and a regular office visit, you should talk to the families about screening kind of at the same time that you're doing things like lead levels and hemoglobin, or if you're getting labs for any other reason, just tack them on there. That's generally what I've done with our other autoimmune kids, and I'm getting labs for that. I will screen their antibodies as well. We don't have a consensus or validated genetic risk scores yet. Again, I'm really hopeful that will develop with time, but then that's going to be another discussion about cost effectiveness and which of these systems is going to work best. There are prevention trials, so I don't think that there's any currently like through TrialNet that are looking at new medications, but things like tillotson is being studied in repeat dosing. It's continuing on in that current study. So there's other immunomodulators as well that are of interest. There's also focus on prolonging early or stage 3 or the honeymoon phase, and here's some of the list there. And then finally, the treatment for stage 4 diabetes, which is longstanding, which is what I have. And that's what a lot of people consider a real cure, which means living without insulin. There's obviously continued development of the technology. Again, that could be a whole different talk, but there's a lot of technology coming out at every conference that we go to that help manage the disease. Other places for real focus is on stem cells and beta cell encapsulation and transplant. It's not been successful yet, but we're getting closer. We do know that even 20 years on, people with type 1 sometimes have like 1 or 2 little beta cells in there making insulin. So there's also a focus on how do we get that and how do we proliferate their own beta cells to hopefully, be more successful if we were to have like a transplant type situation. But we're nowhere, I don't personally think we're anywhere close to being able to do that yet. Okay, these are some of my sources. And if there's any questions, this is the skit with Dr. Reynolds. Yes.
I've seen more adults getting type 1. The family history will be, I got type 1 at age 30.
Yeah.
Does that change the risk factor for the child compared to when it's an adult who says, I got type 1 diabetes diagnosed at age 11?
That's a good question. I don't think we know whether the age of diagnosis of your family member impacts it. We know that the age that you seroconvert impacts your risk for development of stage 1 and also impacts how quickly and what kind of disease course you have. So some people will talk about LADA or latent autoimmune diabetes in adulthood. That is just type 1. It's just that when you're diagnosed in adulthood, you tend to have a less, like a slower course to the stage 4, so to speak, right? So you have a longer honeymoon phase. It's easier to manage compared to when you're younger. Anecdotally, I feel like a lot of families, when there's multiple people in the family, that they're diagnosed around the same time as each other, likely speaking to whatever that environmental trigger is that causes somebody to seroconvert, because if you're in the same family, you're likely to be exposed to the same things. Yeah.
And also, I did ask a question when I was in the car on the way here. The fact that you don't have 100% concordance between monozygotic twins.
Yeah.
What do we think that is?
Yeah, because the environmental factor, right? So monozygotic.
Only one twin gets.
Right,
I mean,
yeah.
presumably twins that are in the same, we only separate twins occasionally.
Right, but not every twin is going to eat the same things, and I could give a little throwback to my old endocrine disruptor grand rounds I did last year too, right? Like we don't know the things in our environment that are impacting autoimmunity, and type 1 is not the only autoimmune disease that is increasing prevalence. I'm sure Dr. Garen LaFlamme can speak to that, right? Celiac's going up, inflammatory bowel's going up as well. Allergies in general are going up. So I think that there's just so many different things you can be exposed to in the environment. And even among monozygotic twins, it just shows that just being born with a genetic risk, it doesn't guarantee you're going to get it, right? 85 to 90% of people with type 1 don't have family history. Some of them don't have the specific HLA type. So it's a difficult thing to really tease out. There's been tons of studies, and I think and you can see if you agree with me, I think I've seen a shift in research into getting away from why there's been a trigger for the autoimmunity to start and more focused on to what do we do when it happens, just because I think the why is, we can't keep up with like viral infection changes and mutations and all of that, right? So it would be a fruitless focus. I don't know if you agree with me.
There are just so many things in the environment. It's so hard to study and to know.
Yeah. Yes, Dr. Gardner?
So I hope this will be an interesting discussion. In the field of genetics, we're very excited about genetic screening to identify populations that are at higher risk, that are going to benefit from more intensive surveillance. So we feel like, in general, screening for what we would consider to be complex diseases, but to try to identify people who would benefit from closer screening. I mean, your talk is exactly this discussion. But we're talking about genetic testing of minors, and the American College of Medical Genetics has quite a few things to say about that. So just for the learners in the audience, I want to let you know, we don't do genetic testing of children for conditions that they're going to get as adults, and we don't like to put something in the chart. I tell the families, like, pejorative. You don't want to identify the child as being at risk for a disorder that they don't have yet, because this may impact their ability to get insurance in the future. Right? So the Genetic Information Non-Discrimination Act of 2008, GINA, says you're not supposed to discriminate against for health insurance for pre-existing condition. And this mostly is happening in the US. We mostly don't do that, but life insurance, disability insurance, long-term care insurance, all of these things are kind of, optional. And also that in the US, we don't have a good way of tracking people who are at a higher genetic risk. When you think about ICD-10 codes, we have Z codes for people with a family history or higher risk, and we have diagnosis codes that start with a different letter, but we don't have a separate category for people who have a genetic risk and haven't developed that disease yet, which leads to a lot of miscoding by professionals who don't understand. You want to talk about what the patient actually has, not what you're worried the patient is going to get. So we don't have a great way for tracking these patients, and there's I think a significant risk for discrimination against people who are identified as being as a higher risk for genetic disorders that don't actually have the disease yet. And these are children who can't consent on their own behalf to genetic testing. When I think about the Australia research that you talked about, I think about, gosh, in the US, newborn screening does not require consent. What did these parents consent to when they enrolled their child in this, genetic study?
Right, and I think it would also, that would be an interesting thing to ask, whether Australia has the same restrictions or concerns about health insurance. Italy's doing mandatory screening. Everybody in Italy gets health insurance, period. That's not the case in the United States. Things like life insurance or disability insurance is a whole different ballgame with genetics, and I would say, yeah, that's a very difficult thing that parents have to consent to. In Australia, it's a pilot study, so these are people that are consenting, doing informed consent. In Italy, it's mandatory. Everybody's getting screened, so they're presumably not consenting. But we do, there are parts of the newborn screen, like cystic fibrosis, where they reflex test for mutations. So you have an IRT that's high, and then they reflex test that for common CF mutations. So there's some groundwork there, I think, but I think that that's a really important factor. Yeah, and I can say personally, I can't get disability insurance, and I never will. And I was 11 when I couldn't get it anymore, right? So like that's something that is a very real possibility. But
I was gonna ask too, like, if having the 2 positive antibodies with that strong of a prediction factor, like, does that count as a pre-existing condition? 'Cause I know, like, when we had that family a few weeks ago with the little one that was like, and their testing wasn't back yet, like, I heard mom and dad already talking about, like, do we need to change our insurance before we know?
yeah, yes. Once you have 2 antibodies, you have stage 1 type 1 diabetes, and whether or not an insurance company calls that a pre-existing condition will probably depend on the insurance company, but my suspicion is they will, because insurance companies have been known to call pregnancy a pre-existing condition. So I think that that's an important factor, but we are protected against the pre-existing condition. As of right now, insurances cannot deny you for a pre-existing condition. That's actually been around for not that long, like with the ACA, but before that, if you had continued health insurance, so you didn't have an interruption, new health insurance could not deny coverage of a condition you had when you switched to them. These are not things that most people probably ever had to know about, that I only know because I personally had to go through this getting insurance when I was 18 before ACA started, right? So this is an important thing to bring up with families when they're considering screening, for sure. Yes.
I think Dr. Doherty brings up some really interesting points about insurance, but I think we also have to remember the impact on the parents, and it could go either way.
Yeah.
Either we could be branding this child and they become medically fragile and the parents sort of, spin out.
Mm-hmm.
And I think about our old diagnosis of asthma, and some parents would just be like, oh, my kid has sick lungs and now they can't do anything.
Right.
And then I think we've gotten better at education, being like, no, asthma kids actually do way better if they exercise. Plenty of Olympic athletes have asthma. You should, persist. And then I think about all the kids I see who have a BMI that is, skyrocketing, and I can say anything I want and nothing happens. But then when I finally have a hemoglobin A1C that's going off the charts, then maybe they're about to change the diet. So we know all our kids are eating terrible things that are not food. And if you were able to say someone with stage 2 diabetes, would that actually light a fire under parents to be able to say, okay, we're not going to just buy you gummy worms every day and let you have high C every day. So it's a double-edged sword, and certainly
I will say that
education is the difference.
Stage 2 type 1, it will not, and like having a highly processed foods is not going to help it, but diet has not been shown to significantly impact progression to stage 3 compared to people with type 2 diabetes, where it does. Okay. Obesity and insulin resistance does make you progress faster if you were to develop antibodies in type 1. Okay. So an important thing to consider, because we have such more significant obesity now and insulin resistance now, that we do get people with that mixed picture where they're developing diabetes because they have type 2, but they also have positive antibodies, meaning they were already at risk for type 1, but they have C-peptide. So clearly, you're not sure which thing is driving that. When we start this screening, so I offer screening to all of my family as my new diagnosis. Sometime, depending on how ready they are to hear more stuff, they have a lot of siblings, I do talk to them about that and offer screening for the siblings. Some families take it, some don't. It's a very personal decision. Some people want to know, some people don't. I have a co-fellow, or had a co-fellow, who has type 1. She has 2 kids. She still hasn't decided if she wants to screen them, and she's a pediatric endocrinologist, right? She's perfectly poised to be able to manage them if they were to develop type 1. So she's kind of a unique position, but I think it kind of shows how different people can be. Some people aren't going to screen. I came from New York, where we had a very large Jewish population. They would not screen any of the women who were not married yet. Some of the families, because if you screened positive, now they had to disclose that. It was part of their culture to disclose it to a future spouse. So they wouldn't do that because it could impact their ability for finding a husband. I don't know why it wasn't the other way either. So there's a lot of cultural things that go into it. You have to talk to all your families and decide on their own.
Yeah. Some of these might have been answered. I don't know. Dr. Hart said, should we screen kids with celiac disease, autoimmune thyroiditis, etc., for type 1 antibodies?
Yes, you should screen all people with celiac disease. And actually, Dr. Cordell had messaged me about a family not too long ago who they brought it up to him because they're on top of that. So Dr. Garen LaFlamme, Dr. Hart, etc., you might be hearing more families requesting this as well. And that's part of why I made that order set, so you could just go into mine and screen with their labs.
How close of a family member should be screened? First order, second order?
Yeah. The current recommendations from the ADA are first-degree relatives for screening. TrialNet will actually screen certain ages with second-degree relatives, for instance, nieces and nephews of somebody with type 1, grandparents or grandchildren of people with type 1, but it depends on the age, and that's more in research right now, but we do know that they have some increased risk as well.
What is the current status of non-invasive continuous glucose monitoring?
Current status of non-invasive continuous glucose monitoring. Non-invasive, I would think what we have now is not that invasive. It's a filament under the skin. I think this is probably referring to some people seeing on Amazon like a glucose watch that reads your blood sugar through kind of like a pulse oximeter. Those are just pseudoscience. They're not studied, they're fake. So I don't think that we're close at all to that. I think there's some that
now there are glucose monitors that are available over the counter for your patients to purchase without a prescription. There's Abbott is making a product, and then there's also which I can't remember. Yeah, and then Stello is like the Dexcom equivalent. Yeah. So you could have people doing this without a prescription. And generally for pediatric patients, we don't typically recommend people do that because they have a lot of false low and false high readings, which can cause a lot of anxiety. So it's not something that we would generally advise PCPs be recommending for their patients. I would advise against that. Now, if we had a patient who had stage 2 that we were following in our office, you could potentially use intermittent CGM use for monitoring, probably monitoring more from progression of stage 1 to stage 2 for catching that dysglycemia. That would be an option, but that would be something that would be better for us to do so we can make sure the families really understand the limitations of those devices. In another side note, there are also over-the-counter hemoglobin A1C kits that people can purchase and do at home. I think I've seen some data that they're reasonably accurate, but even with our lab A1Cs, there's a pretty significant margin of error of the lab A1Cs. So people get referred for borderline A1Cs, and then we repeat them, and they can be half a point different. So you just have to remember that when you're looking at that. But yeah, one more question.
How is the insurance coverage for teplizumab in patients?
Oh, goodness.
Yeah, and I don't know that you mentioned the cost.
Yes. Oh, yeah, okay, I did not mention the cost of teplizumab. It's very expensive. Lori, what's the cost if you were to pay out of pocket?
$200,000.
$200,000 out of pocket.
Yeah,
I will say the first patient we had at our center in New York didn't pay out of pocket for it. So some people are doing that. New York's a different world, y'all. Insurance coverage is generally, I think, good, but I think there's just been such few patients that we've had really on it. So I've heard a range of no copay up to the deductible for the year once it gets covered. The company themselves do a lot of the hard work on helping to get that insurance coverage. But it does take time because it is such an expensive medication. So that's another reason why when they're progressing into stage 2, we really want to catch it at that point and get that process started because, we definitely had it when I was in New York with one patient where we weren't sure insurance was going to cover in time before they went to stage 3. And once you hit stage 3 diagnosis, you don't qualify for it anymore.
Do we currently have any patients at Carilion on it?
On teplizumab, there was
We have
one
treated at least one patient.
One that has been treated that I don't think has developed type 1 yet, or stage 3. And in New York, I think we had 3 or 4 before I left fellowship. So I graduated fellowship in 2024. So it had only been out 2 years, and we were the only center doing it.
And the insurance has something to say about whether, how much is in the infusion center versus home health. So I think for the patient that we did here, they had maybe the first 5 doses in the infusion center and then the rest at home health, which is it's probably good to have the first dose here so you can monitor for side effects, but then people probably don't want to come for 14 days to the infusion center, and weekends become tricky for that. So, but I think that insurance company had specific feelings about how many doses would be given where.
Yeah, and in New York, it was all at home health for those that got covered by insurance. It's going to be different depending on your institution. Any other questions? We're good? Okay, cool. Thank you all.